Afternoon, everyone. Welcome to the Yale Sleep Seminar Series. My name is Brian Miner, and I am here today not just as a participant, but a host because I have been working closely with Dr. Adirim over the last year, both in his work as a clinical fellow and with some of the research that he's doing. So before I introduce Zach, I'll just make a few brief housekeeping announcements. So please take a moment to ensure you are muted. In order to receive CME credit for attendance, please see the chat room for instructions. If you have questions or comments during the presentation, please use the chat room or take the opportunity to unmute yourself at the end of the talk and ask questions. I will be monitoring the chat, and I'll use my discretion, Zach, to say whether we should answer questions as we go or save till the end, if that's okay with you. Okay.
Sounds good.
We are recording today's talk, and the recorded version should be available online within the next 2 weeks. And that link will also be in the chat. So moving on to our talk for today, it is my pleasure to introduce Dr. Zach Adirim. I realized recently that I was not pronouncing his name correctly for most of the year. So Dr. Adirim, before coming to us, as many of you may know, he's actually Canadian. And so he did his Bachelor's of Arts at McGill University in Montreal. And for those of you who don't know, it is the Harvard of Canada. Isn't that right, Zach? I know because I went there too. So that's how I know it's the Harvard of Canada. And then from there, he went on to do a doctorate of medicine at the University of Sydney in Australia and moved on to a psychiatry residency within the University of Toronto. He also spent some time there as a chief resident and was recognized over the course of those years, both for his excellence in teaching and also for his scholarly work. And he then joined us for a sleep medicine fellowship, which he is, I don't know, about 3/4 of the way through completing. He did some work when he was still in Australia at the Brain and Mind Center in the Department of Neurology, where he investigated motor neuron disease and frontotemporal dementia and published some work looking at neuropsychiatric symptoms of ALS and their impact on caregivers. And also did some work during his time at McGill, looking at the linkages between emotion regulation difficulties and engagement and risky behaviors. And so, in his time here, I think we all have experienced the richness of thinking about sleep in this sort of social and psychiatric context that Zach brings. He's a wonderful clinician, very thoughtful, very engaged with his patients, and I always enjoy the perspective he brings as a psychiatrist. And in working with him over the last year in this research, you guys will see today the depth of knowledge that he has gained in the topic is really impressive and has helped me so much to understand the landscape of what we know already about the circadian system and sleep and what we still need to figure out. So I think you guys will be equally impressed as you listen to him give this talk about all of the things he'll be able to teach us today about the circadian system and long-term health, more than just sleep duration. So without further ado, Dr. Adirim, I hand the mic to you.
Thank you very much, Dr. Miner, for that wonderful introduction. And as a colleague since the days in McGill, although we didn't know each other then, it certainly feels working with you now that we have known each other for a long time. And I've appreciated all your guidance in the research we're doing together and in this presentation itself. So hello, everyone. I'm Zach. I'm one of the fellows at Yale, as you've heard, with much more context from Brianne Miner just now. And I'll be talking about the circadian system and long-term health today. So here's the usual CME slide for Yale continuing medical education. So there's some instructions on here on how to obtain the CME credit. There should also be some instructions added to the chat, which you can follow in order to make sure that the CME credit's applied for attending this. So I'm starting off just with a quick slide here that seems to resonate with most people and speaks a little bit to circadian rhythm and how things end up. So today we're going to be talking about the circadian rhythm in a few different ways. First, we're going to review general circadian concepts, methods of measurement, and clinical assessment of circadian rhythm. We're going to then move to discussing recent research and advances in how circadian rhythm links to long-term health outcomes across a few different spectra. And then lastly, we're going to close up by talking about where future avenues of research look like they're kind of anchoring and what kind of promise they may hold in circadian rhythm and how that translates to the clinical setting. So to start off with, we're going to go through a little bit of background of circadian rhythm, and we're going to go way back all the way to the 1700s. Jean-Jacques Dortu de Marin, my accent definitely gives me away a little bit as an Anglophone Canadian, but this natural philosopher way back in the 1700s is really one of the first people credited with scientifically observing the circadian rhythm. As you can see in the photo here, essentially what experiments he was able to do were to demonstrate this plant, often referred to as the touch me not plant, when kept away from light exposure, still exhibited the opening and closing of leaves in accordance with when one would expect the sun to be out and the night to come, which of course did demonstrate that there is the ability of the plant to recognize a day and night cycle even without immediate exposure to light prompting that. We're skipping ahead a couple hundred years quickly to the 1930s. Dr. Kleitman established the world first sleep laboratory around this time after spending 1 month in Mammoth Cave with no light exposure at all, with a plan to adapt a circadian schedule to a 6-day, 28-hour week, with the idea that there could be some arbitrariness in the way that our sleep cycles work. One person adapted, one didn't, but this really ignited some scientific inquiry into circadian rhythms themselves. We're skipping ahead another few decades. Sifra, who is a cave explorer, actually with some funding from NASA in the context of the space race around that time, was able to get funding and look at experiments spending really, really long time periods in caves without any light exposure at all, with monitoring of things like temperature, brain waves over time. And really out of this came some development of what a circadian rhythm looked like that's normative, or that looks like it's common in humans, which looked like a rhythm slightly longer than 24 hours on average, that would gradually shift later and later. And as we can see on the image on the bottom right here, we see that with sun exposure, the rhythm stays roughly similar altogether. But what they saw is that it can become free running without sunlight exposure, or what are called Zeitgeber exposures, which I'll touch on later on, that it moves later and later. And we can see the bedtime can actually shift later and later and later until we've kind of come full circle. Now, since the 1970s, there's been a tremendous additional amount of research in the area. There was a discovery of a gene mutation that could affect circadian rhythm length by Konopka and Benzer. Warren Zucker discovered the suprachiasmatic nucleus as the center for mammalian circadian rhythm with direct input from the retina, which I'll speak on a little bit. Moore and Klein discovered the pineal gland, deriving some melatonin output from input of that suprachiasmatic nucleus. And then a Nobel Prize winner, Hall and Rosbash, won that for isolating the PER gene, discovering the self-regulatory feedback loop of the PER protein and period protein. And Takahashi discovered the clock gene more recently. And we can see, up top there, a photo of the Drosophila fly, which is responsible, they say, for about 6 Nobel Prizes just from the fly itself. And we can see on the lower right here an image of what gene transcription looks like in the liver. And we can see that there is a circadian component, which we can see peripherally, even in a small slice of just liver cell. So moving forward to what is circadian rhythm in terms of concepts and in generality. So it's Latin for circa, meaning around, and diem, meaning day. The roughly 24-hour oscillations in numerous biological processes. So sleep, wake, hormones, body temperature, eating, digesting, plus, many, many aspects of life. And it's observed in a broad range of organisms, from fungi, cyanobacteria, to animals, controlled by internal clocks, as I mentioned, kind of demonstrated by the plant experiments all the way back from the 1700s, that there are internal clocks that you're managing this. And there's a lot of theories about how evolutionarily this would have come about. It originates very, very early in life, down to some of the earliest organisms that have ever been studied. And essentially, hypotheses include things like safeguarding DNA, because in bacteria, exposure to DNA could mean damage and end of life, essentially, for bacteria, to obtain as much sunlight as possible, as I mentioned in that plant example, in order to make sure they get that light exposure, which is energy giving, or prepare for the active day and night, for instance, in animals or in ourselves. And the photo on the right is the jantar mantar, which is I think, one of the largest sundials in the world, and it's in Jaipur, India, which is a beautiful city I had the privilege of visiting. So talking more about what the circadian rhythm looks like, it's, as I mentioned, it's centered in the suprachiasmatic nucleus and the hypothalamus as the clock generating central rhythm. There are input pathways that transmit environmental cues that help entrain and keep that circadian rhythm steady. And the major source is in the retina with melanopsin in retinal ganglion cells with their own kind of direct link in order to modulate that, that's separate from some of how vision is processed. And then there's lots of modulators. So we think about things that are sight givers or light givers, derived from German. And these are things that just give our body an indication of what time of day it is. For instance, light, but food intake as well, socialization, temperature outside. These are ways that our body sticks to a rhythm. And then there's output pathways to hypothalamic nuclei, to the pineal gland for melatonin release, pituitary gland for hormonal release, and really with widespread effects around the body. And I should say I'm focusing here mostly on central circadian clock. There are peripheral clocks that are now kind of shown in multiple organs of the body and in different locations, which kind of prevent some feedback as well. And what we could see on the top right there, that graph, is a demonstration of some of how the circadian rhythms move. So cortisol, we can see, follows in blue with a specific rhythm, kind of peaking as we're entering into the morning and helping us wake up and from alertness. From that standpoint, we see melatonin release in green following its own curvature. Alertness, of course, following curvature aligned with the day-night cycle, and body temperature as well, which reaches its nadir about 2 hours before wake time or so. So how does this affect our sleep and our alertness? So there's a two-process model most of us are probably familiar with in sleep medicine. Those are the circadian process and the sleep homeostatic process, which help with sleep and wakefulness. And we can see that there is essentially a gate that opens around bedtime usually, where they both move in the same direction, which helps to bring sleep on. And a couple of quotes I've listed here from Dr. Krieger here at Yale himself around sleep and wakefulness are only maintained in consolidated fashion when the signals are appropriately aligned. And this is reflected in the ICSD, the importance of sleep only really working well if it's aligned with circadian rhythm. So how do we look at circadian rhythm in the clinic? First off, of course, we can clinically assess it on history taking as the first time we meet a patient. A lot of our clinics would use, standardized measures to get an estimate of circadian rhythm, and morningness, eveningness questionnaire is one of the most utilized one. It's kind of used as a derivative of circadian rhythm, but it's really asking patients about their preference for the day-night cycle, the time they go to bed. And there's an excerpt on the top left image there. Questions are things like, assuming adequate environmental conditions, how easy do you find getting up in the morning? And people tick off a series of questions around that to estimate whether they're more morning types, more evening types. Sleep diaries can help us get a guide. But the gold standard measures really are objective measures that are physiologic. And there we're thinking about salivary melatonin for the dim light melatonin onset in the evening prior to bedtime, or 24-hour temperature measurement is sometimes used. Now, clinically, of course, these aren't always available, nor are they always really feasible clinically, but they're certainly the gold standard measures that are often used in research and sometimes in kind of specialized clinical environments. We can see on the right side here what dim light melatonin onset looks like. So up top, we see someone who might be circadian delayed, who's getting that onset around 1:30 a.m. And on the bottom, we see someone who's getting that onset around 7 p.m., whereas for most folks, it would probably be somewhere in between. So additional circadian measurement that is used clinically sometimes, but also used in research heavily, is using circadian monitors, which are really actigraphs. And these are digital pieces of equipment. You can see a Philips device up top there, for example, that have shown to be very correlative to physiologic measures of circadian rhythm, like dim light melatonin onset and 24-hour temperature measures. And they provide a bit of a benefit of providing some habitual data over time. And so data that can be derived from include like activity, rest, total sleep time estimates, bedtime, wake time, sleep midpoint. And up top on the right there, we see some reading from an actigraph. And we're seeing there the black lines of activity, and we see the period of sleep time where there's a bit less activity there when it looks relatively consistent. There's also some advanced data, and there's been a lot of work on this in more recent years around what we can gather from the actigraphs that are in addition to those kind of basic general data. And using cosinor analysis, which is a model assuming kind of periodic sine waves parameters statistically to certain phenomena like circadian rhythm has been applied to look at a few different parameters. So amplitude, which is the difference from kind of the average activity and the peak level, mesor, which is the mean level of activity, acrophase, which is the general period of peak activity during the cycle. And then there's additional kind of measures that have been developed more in recent years, even in addition to that. And these are using non-parametric data. So they do not assume that cyclic sinusoidal wave of the circadian rhythm. And they've been able to, by using this data, find some newer measures of circadian rhythm as well. And these are things like interdaily stability, which is a measure of the stability of the circadian pattern over days. So if we look at the figure on the top right here, we can see that on the top, that's an indication of someone who has pretty good interdaily stability. So each day looks pretty similar in terms of what their rest and activity looks like. They're sleeping around the same time. They're getting their peak activity around the same time. And we can see on the lower part of that figure, it's a little more scattered. Some days you can see that the activity spread throughout the day. Some days it's narrower. Some days there's not that much activity at all. And so that's an indication of how things work between days. There's also a measure called intradaily variability, and this is looking at the circadian pattern during the day. For instance, by the hour. So is there sleep, or is the person going in and out of activity and sleep during the day itself, like with naps? And so moving to using some circadian assessment, there are, of course, circadian disorders that we think of presenting to the clinic and ways we can kind of focus on that in order to gain improvement in people's sleep health in general. And just to briefly touch on these specific circadian disorders, which aren't so much of what I'm going to be talking about today, but just to review, there are some parameters around specific disorders like delayed sleep wake phase disorder, advanced sleep wake phase disorder, irregular non-24 hour. And then, of course, there's occupational ones too, like shift work, jet lag. This is just a nice figure to show what they look like. So delayed sleep phase, basically the sleep period is just later than it would be, which is normative for most people. And society, of course, can have impacts on people depending on their natural circadian rhythm. Are they showing up late for school every day? Are they able to get through the day at work? Advanced sleep phase is the opposite. So going to sleep earlier in a sleep period than most people would. And we can see irregular and non-24 hour are a little bit different in terms of the way they're derived, with either a free running circadian rhythm or one that's just so irregular it's difficult to tabulate a specific rhythm to it. So switching gears to talk about how the circadian system impacts on long-term health. This is a photo of Ernest Hemingway and a quote from one of his books talking about it appears someone who has pretty significant circadian phase delay. He would lie in bed and finally with daylight, he would go to sleep. And Ernest Hemingway, of course, has a very colorful history in terms of his personal life and in terms of his struggles with mental health, along with being an excellent writer. And I think it touches on, in some ways, some of the mental health, and we think of other health implications of having sleep disruption and circadian phase adjustments. So let's start off by talking about how circadian rhythm is known to affect sleep quality. So how does it affect insomnia? And we'll start off by reviewing some literature on initiation insomnia. So we know that initiation insomnia has been shown to be associated with endogenous core temperature rising later than is kind of usual. Dim light melatonin kind of rising up a little bit later, which suggests an element of delayed sleep phase, at least in some patients with initiation insomnia. We also know that insomnia treatment combined with light therapy can enhance some benefits for sleep latency and for total sleep time, again, suggesting an element of circadian aspects to initiation insomnia. Now, for maintenance insomnia, we do know that there's associations of this with lesser decreases in nocturnal core temperature, so maybe less of a robust circadian rhythm in that way. Conflicting evidence about melatonin production in general. And there is associations between maintenance insomnia and altered dim light melatonin onset. And then when we think about early morning awakening, there's also just some at least parameters of research that demonstrate an association with circadian disruption. So an earlier temperature nadir, melatonin markers being a little bit different, which could suggest an earlier phase. And we know treatment with evening bright light therapy can help with wake up time and increase total sleep time by presumably treating a little bit of an advanced phase in those cases. We know that circadian preference for eveningness is associated with worsened insomnia. And that eveningness is a term from chronotype, which is from the morningness, eveningness questionnaire in terms of circadian preference itself. So how does circadian adjustment affect sleep physiology itself? There's a lot of conflicting evidence in this sphere. So we know that circadian associations have been shown in some studies to affect sleep onset latency, to REM sleep latency, but these are really, really small polysomnographic studies, usually with one night reading. So it's a little difficult to derive too much from this. There was a pretty recent study done showing morningness was associated with better polysomnographic sleep quality parameters in general. So total sleep time, sleep onset latency, total REM amount, arousal index, when compared with people who prefer an evening type sleep schedule. So in terms of otherwise sleep quality, we know that evening chronotypes associated with poor subjective sleep quality. And evening chronotype is also associated with worse daytime sleepiness. So in terms of take-home points here, what is the gist of the research that we can review in this area? Circadian disruption and evening preference have a clear association with insomnia, and including with different types of insomnia. There's pretty limited literature showing the association of circadian rhythm adjustment with objective sleep physiology, as I mentioned, but evening chronotype certainly has a well-studied association with other parameters of sleep quality, so subjective sleep quality itself and higher daytime sleepiness. And we're going to pivot now to talking about how circadian rhythm is known to affect geriatric conditions. So we do actually see that aging itself is associated with changes to the circadian rhythm. So we see impairment in circadian rhythmicity, an earlier general phase, which we're all probably familiar with from seeing older folks in the sleep clinic itself. And we also see changes in some of those advanced actigraphy measures in some research. So a higher intra-daily variability, decreased amplitude in total. And we also see decreased day-night contrast, maybe some reduced sensitivity to light actually from retinal changes with age. There's suprachiasmatic nucleus changes that have been shown with aging itself. And we know that lifestyles may change with age, given mobility differences and the way that people's lifestyles may be different as they gain age. And actually, there's a very interesting recent article which used actigraphy, light exposure, and 24-hour temperature measurements to actually train an AI model to estimate the age of an individual. And they use that by sampling some younger age folks and older age folks to develop a model using that data. We also know aging is associated with impaired circadian immune function, and this is from looking at some of the circadian immune genes and how those are expressed. And we know that light therapy has been shown beneficial to circadian retrainment, sleep quality, health, and cognition. And this is some small studies around institutionalized older adults. And so what take-home points do we have around aging? There's a clear association with aging and circadian advance. And we know this clinically. We know this in terms of some of the research findings. And there's an emerging association with kind of a more specific circadian profile change with age. And there we're thinking about the higher intra-daily variability, maybe a decreased amplitude of the rhythm. And just to remind ourselves that higher intra-daily variability is meaning within a day, more alteration in the rest and activity. So that could be accounted for by naps, by falling asleep, dozing during the day. And then decreased amplitude, that's less activity versus rest in total. So kind of a narrower curve for older folks. Now I'm just going to show a brief graph from that study I mentioned, which actually tried to use AI to estimate age. So this is a 2018 study where younger adults and older adults were recruited with measurements of actigraphy, distal skin temperature, body position, and really obtaining that environmental data to train a model using decision tree analysis, which then could estimate age based on those parameters. And in green, we see the actigraphic curves for younger patients, and in red for older patients. And ultimately, they were able to train the data to be able to estimate in the small sample of over 90% accuracy to differentiate between younger and older. And I think this just points to an interesting place where things could move in the future, where is there a specific signature around circadian changes as we age? But just to return for a moment and think about other parts of sleep that can sometimes be associated with circadian rhythm and how those can affect or be affected with age. So we do know that long sleep duration, insomnia with short sleep duration are associated with short telomere length in one study. And here with the red sunglasses, we can see some of the odds ratios for the short telomere length. So we can see it for long sleepers, so people who slept over 8 hours in this study, short sleepers who also had insomnia, and people with insomnia in general. But another study done not too long ago, which was a cohort study where people estimated their own sleep duration, chronotype, we saw that in that study, actually, circadian disruption was associated with shorter telomere length and not insomnia or sleep duration. So I think suffice to say, it's a little bit more of a mixed bag on how much of this is circadian versus sleep duration. Certainly suggestion that circadian is a major, major component to it. Switching gears to talk about cognition. And so circadian alteration and cognitive dysfunction has a really more recently described association that a lot of studies are looking into. And so there's cross-sectional data to show alterations in circadian rhythm are more frequent in Alzheimer's disease. There's some studies which show it can precede institutionalization. And then there's a study that was done actually showing that alterations linked to amyloid pathology, even in intact populations. And there's studies kind of proposing a mechanism by looking at this association in cohort studies. Could circadian alteration be an early symptom that's common to multiple neurological diseases? There's a kind of a large cohort study with the Mr. Oss cohort that looked at circadian alteration in rest activity rhythms, which was associated with cognitive decline in that study. And now there's some more recent studies in recent years looking specifically at developing cognitive impairment and trying to look at that association over time a little bit more. And there's studies showing that less robust circadian rhythm has been associated with incident MCI and dementia, earlier sleep-wake time, smaller day-night activity differences with incident dementia, and markers of what I've called here just circadian weakness or less robust circadian rhythm have been associated with incident dementia and even progression from mild cognitive impairment to Alzheimer's disease. So this really is an emerging area. As take-home point, circadian disruption has this association with amyloidopathies and most notably with Alzheimer's that's been shown. And there's some early evidence that circadian disruption could be an early marker along the pathway to neurocognitive disorders. And that's still a lot of that research is to be done to clarify this link. So how about other factors that are associated with circadian rhythm? So things like sleep duration and insomnia. And there is some interesting findings around this. So short sleep duration, prolonged sleep latency, sleep disturbance are also associated with dementia potentially. Development and progression of Alzheimer's disease have been linked with short and long sleep. And sleep quality has been associated with all-cause mortality, but in the past, that's been potentially explained away by comorbid depression once that's controlled for. Now, in terms of sleep architecture changes, there's also some studies showing, as we may know, like slow wave changes as we age, and is a significant loss of slow wave sleep, which is thought to, of course, be potentially restorative, and there's now a lot of proposed mechanisms to the glymphatic system and otherwise. Is this a potentially risk factor for dementia as well? And there's some studies that have shown that. And we know sleep apnea also has some associations to cognitive decline over time. So how to take a take-home point from some mixed bags here, I think, is that there's a lot of associations of poor sleep health with cognitive decline as we get older. That doesn't make the circadian associations disappear. And in fact, I'm going to speak on that in a moment in terms of when there's been studies kind of looking specifically at how much of this is sleep duration, how much is circadian rhythm, and we'll return to that. So looking at, just morbidity, mortality over time with altered circadian rhythm. So in terms of studies that looked at mortality, and they have shown that there's an association of impaired sleep continuity, so some fragmentation of sleep, the sleep rhythm being altered with all-cause mortality. And the stability of the rhythm being altered has also been shown to be associated with all-cause mortality. And in terms of morbidity, we've seen associations of things like insulin resistance. We know shift work disorder has shown risk factors for cardiovascular outcomes, but also for things like cancers and also type 2 diabetes. There's a study that has shown circadian alterations have been associated with more ED visits for people with congestive heart failure as well. And there's some more recent studies showing just light exposure at night the next morning can have effects on insulin resistance and associations over time with obesity. So there's clearly some emerging evidence around circadian rhythm's importance for our kind of long-term health with things like chronic disease and even with overall mortality. And again, I'm going to return to just talking about some other factors that have this association. And there's an important one, which is for mortality, sleep duration has been shown to have a U-shaped curve with all-cause mortality. And that being, if we can picture on one end of the U, is being a short sleeper has been shown to be associated with all-cause mortality in the longer run. And then when we get to the more normative hours of sleep, so somewhere in the middle there around what's usually kind of recommended, so something like 7, 9, 8, 9 hours, that's shown to be a lower mortality risk. But then when we get above a certain threshold, there's shown to again be a mortality risk for long sleepers. And so this has been shown in a few different studies. And there's actually this U-shaped curve has held for looking at certain morbidity outcomes too. So things like cardiovascular events, metabolic syndrome, diabetic retinopathy, and general chronic disease. And long sleep itself has been associated with stroke prevalence, with obesity, with inflammation, short sleep with, interestingly, similar kinds of morbidity outcomes. And we know that sleep, in one study it suggested, which I think is kind of what I'm mentioning around the U-shaped curve, is sleeping in the normative amount is associated with lowest cardiometabolic risk generally. Studies back that up. So we get to thinking of, is it the duration of sleep then, or is it sleep regularity that has some of these negative outcomes on morbidity and mortality? And interestingly, and I'll speak to a more recent study that specifically looked into this, but there's studies showing that the association of sleep continuity and rhythm with mortality, that link, when you account for sleep duration, has been no longer significant in one of the studies. Chronic sleep restriction has not been shown to affect insulin resistance, interestingly, whereas circadian disruption itself does. And another study has shown that sleep regularity has been associated actually with all-cause mortality, with other causes of mortality as well. And it's actually shown to be a stronger link than with sleep duration. So we have a bit of a mixed bag with definitely a signal suggesting that circadian alone is definitely having an impact on morbidity and mortality in the long run. And I'm going to talk about a really recent study here, which specifically was looking at this question using a prospective cohort model. And so it was a very large prospective cohort study with over 500,000 participants in middle age. They drew on measures like actigraphy over 7 days. And through this, we're able to derive, importantly, 2 different measures. So one being a measure of circadian rhythm, and that's the sleep regularity index. And one being a rough measure of sleep duration, which is a little simpler. It's just counting how long they were asleep. And what the researchers did is they split people into quintiles and compared, for instance, the shortest sleep duration folks, according to a quintile, to the upper quintile sleep duration folks, and doing the same for sleep regularity. So the lowest regularity were then directly compared to groups who had higher sleep regularity. And they measured covariates, which were important socioeconomic factors that we can see here, and other measures of health. So for instance, being treated for hypertension or cholesterol, smoking, measures around shift work status, which we know are associated with outcomes. And so they did a pretty good look at these people's health and followed them over time. And what they saw interestingly was when looking at sleep regularity, sleep duration, and all-cause mortality, which was the primary outcome they looked at, we can see with the red arrows here, the hazard ratios were quite a significant margin lower for sleep regularity folks than those with sleep duration differences. And so what I'm looking at here with the red arrow, what we're looking at is the hazard ratio. So this is in comparison to the hazard of being in the lowest quintile and mortality outcomes. And so in the groups that have a bit more regular sleep or sleep a bit longer, how do they compare to their peers who sleep less or have a more irregular circadian rhythm? And what we can see, the numbers here is for SRI, which is sleep regularity, in the adjusted model, which is at the lower half, the hazard ratios are kind of thereabouts in the 0.7s generally for the more regular circadian rhythms, whereas they're more in the 0.8s and 0.9 in sleep duration. So the impact of being a more regular sleeper, this is suggesting, provided more protection than did sleeping longer. And sleep regularity remained a significant predictor of mortality in models that included sleep duration and adjusted for covariates that I mentioned. And so we can see at the top, the unadjusted model, there's a lot of stars there of statistical significance. And we can see in the fully adjusted model as well, just more powerful statistical significance was seen with SRI, which is sleep regularity, than it was with people who slept longer. They did some model fit analyses, which showed sleep regularity provided a better fit to mortality outcomes than did sleep duration. And we'll just take a quick glimpse at the secondary outcomes, which were cause-specific mortality, so cardiometabolic, cancer, or other cause mortality. And we're looking at the red sunglasses again here. And we can see that in the unadjusted model, sleep regularity was really showing to be very statistically significant associated with lower cardiovascular cancer and other cause mortality, whereas sleep duration only did that show significance around cardiometabolic, When we adjusted for when all adjustments for covariates were done by the researchers, however, a lot of those statistical significance did disappear, but there was some that remained with a bit of a mixed bag where sleep duration, as we can see, actually showed some significance in cardiometabolic mortality specifically. And these are just a couple curves around on the left side, sleep regularity, so a measure of circadian rhythm, and sleep duration on the right side, looking at survival curves over time. And we could see those who had really low sleep regularity, that bottom quintile, that curve looks pretty nasty, where in comparison, there's a clear separation kind of with the rest of the group. But we do see that increased sleep regularity looks like it just provides benefits as you go more and more regular on that curve. Sleep duration, we can see there's a separation from those who sleep the least. And then the group kind of narrows and sleeping as long as you were kind of within range. And we can see what those times were pretty much between 6 and 7.5 hours in this study. Those curves are kind of pretty close together there in terms of all-cause mortality. So I'm going to switch gears and talk about the circadian rhythm and its impact with mental health a little bit here as our last component. And we know that sleep disruption is heavily associated with psychiatric illness. And we know that not only is it heavily associated, but really it's in the definition of psychiatric disorders, of a number of them. So these are excerpts from the DSM, the Diagnostic Statistics Manual, which is the most kind of recognized, especially here in North America, around psychiatric diagnoses and the true definitions of them. And this is the most updated. We can see here insomnia or hypersomnia, a core symptom of depression. Decreased need for sleep. Of course, we know this as a very core symptom of bipolarity and specifically hypomania and mania. Sleep disturbance being a clear core symptom of anxiety. And of course, trauma-related disorders. We know that dreams and increased arousal during sleep is a core symptom of that as well. So it's pretty inseparable to think, I think, in some ways around how much sleep disruption and circadian components are associated with mental health disorders. And so to touch on some of the literature around how circadian rhythm touches on this, there's been a good amount of studies now showing that evening chronotype is associated with depression, depressive symptoms, and actually associated with suicidality and depression. Lower circadian activity has also been associated with suicidality and depression. And there's some studies showing that antidepressant treatment for folks with depression has actually been able to regularize their chronotype, which is kind of an interesting finding, and I think something needs to be built upon a little bit more. In bipolarity, we also see a significant association. So evening chronotype, again, associated with negative outcomes, associated with suicidality. And even between episodes, which is interesting. So, of course, both of these disorders are thought of mainly as episodic illnesses that are chronic over time, but with discrete episodes of mood disturbance. And inter-episode patterns are actually show differences as well in patients with bipolar disorder. And we know that even when they're euthymic, that's different as well in terms of their circadian preference. And there's a study to show that part. So in terms of the gist from this, evening chronotype definitely has a pretty well-studied and robust association with depressive symptoms, depression, and there's emerging evidence in bipolarity as well. These studies mostly rely on chronotype, so people's estimate of their preference, rather than objective actigraphic data or other objective circadian markers. And how about in other psychiatric disorders? So we mentioned anxiety, which of course has sleep disruption as a core symptom. Eveningness again looks kind of nasty in terms of anxiety symptoms and anxiety disorders, and some studies that have been done looking at that. Eveningness is associated with higher ADHD scores, which I think we can kind of postulate and think about how being an evening person, maybe getting a little less sleep, that's not going to affect our attention too well in the longer run. There's some emerging evidence in psychotic disorders and substance use, again, of delayed sleep phase or of circadian preference for later in the night being a poor marker. And then some research around suicide itself. And this is around the peak times of risk of suicide, especially in the overnight hours. And I'm going to speak to this a little bit more. But overall, I think in these other psychiatric disturbances that aren't mood disorders, there's kind of emerging evidence now around the evening chronotype or being a more of a night owl type being negative for overall mental health in these other disorders as well. How about other factors of sleep that aren't just circadian rhythm? So sleep duration, insomnia. We know that insomnia is very common in mental disorders. And in fact, as you saw, insomnia itself, if not a standalone disorder, is a core symptom of psychiatric disorders as well. And this has been shown both during remission and acute mood episodes, or even in early psychosis, that insomnia is more common. Hypersomnia is associated with bipolar relapse and coexists with insomnia in a good proportion we can see of patients with mood disorders. And I should say, to coexist, that should mean that the insomnia is not better explained by depression itself or by bipolarity itself. So it should be quite significant in order to be a standalone disorder. We see that poor sleep continuity and shorter sleep times associated with depression, anxiety, chronic psychosis. And we know that sleep restriction is a clear trigger in bipolar disorder for manic and hypomanic episodes. So much so that many of the best preventatives for our folks with bipolar disorder is sleep adjustment and making sure that sleep is steady. And that has some of the most powerful effects. We're going to look here at some graphs around how does this, as the day goes on, how do psychiatric symptoms change? And this is from a recent review of a mental health and circadian rhythm evidence. And we can see on the top left there, mood adjustment during the course of the day from some of the studies they reviewed. And we can see that mood kind of improves as the day starts and gets going around 1 o'clock. And then there's a little drop in the afternoon, comes back up, and then starts going down as we're going to sleep. Just below that, we can see anxiety symptoms in generalized anxiety disorder. And we can see anxiety is peaking early in the day and then gradually reducing over time. We could postulate interesting things like cortisol rhythms and different things around that, but this has been shown around anxiety. And then the bottom left here, and there's even larger red sunglasses on this one. You can see this kind of mountain peak, really, that is in the overnight hours around suicide risk in the general population. And I'm going to touch a little bit on that and some theories as to why that may be. So why is the suicide rate higher at night? This concept of the mind after midnight. And a few hypotheses I'm going to be talking about here are largely derived from Perlis et al. And some review studies that have hypothesized some aspects here. And they hypothesize, there could be an element of hypofrontality or reduced function of the frontal lobes during those times. Sleep deprivation has been associated with loss of forebrain activity, maybe higher waking delta, theta, and alpha in frontal areas. And also the circadian night itself, so just the circadian component of this has been associated with hypofrontality as well. Is there an element of impaired judgment that comes on in the middle of the night when people are awake? So sleep deprivation, again, is associated with cognitive changes, so more emotional judgments, maybe some changes to risk preferences, which isn't surprising when we're, exhausted. But also circadian night itself is associated with lower cognitive performance, inhibitory control impairment. So are we kind of more impulsive at those times? And then we can think about that graph we just found around circadian mood. How does the mood fluctuate during the day? And we saw it reaches its nadir in the pre-sunrise morning, and that's a circadian component itself. And then there's a kind of a mixed bag, which is interesting around sleep deprivation and mood, because there's been old findings dating back decades in the psychiatry literature that acute sleep deprivation actually has antidepressant effects. And we can mostly relate to this if we've had to endure 26-hour call or whatever we've had to deal with in our medical background. But there's often an immediate kind of glow or like antidepressant feel that one can get from sleep deprivation. And so that kind of runs contrary to what we'd think of with sleep deprivation for people who are up in the middle of the night. And so there's some theories that the authors kind of proposed around, are people who happen to not respond to sleep deprivation mood effect the ones who end up dying by suicide, for instance? Or are the benefits for mood from sleep deprivation not seen until a little bit later? And so got to get past that period of the circadian night. Otherwise, there's kind of a hypothesis, is it possible that the part of antidepressant effect that comes with sleep deprivation is actually more energizing than it is changing of our inherent emotions? And this is a similar theory to that explaining some suicide risk with antidepressant treatment. Is the effect actually taking more of an act on the energy of a depressed patient rather than before they've actually had the mood lift itself? And so then rendering people to a little bit of higher risk of suicide in the night. And so I think what we can say from that is it's a really interesting part of the literature right now around, is this a circadian component, sleep duration component around these suicide risks, especially in the middle of the night. And of course, there's sociocultural elements when we think about being alone with our thoughts when no one else is around in those times, of course, can be a dangerous mix. So I'm going to touch on, the pathways of future circadian research. And first, just talking about sleep quality itself. So there's certainly been some work, as I had mentioned, around how circadian changes are in older adults, but there's been some conflicting evidence around how objective sleep quality changes and how circadian alteration changes, especially with some of the newer conceptions. So things like interdaily stability, intradaily variability, amplitude. And so I think there's certainly some more research that can look into how this exact circadian rhythm is altered with age, with some of those advanced measures. And also, we'd maybe expect some differences because as we get older, most people's circadian rhythms advance. Does that change their chronotype as well, their preference for being an evening person as they end up shifting naturally forward? And how does circadian profile associate with objective sleep quality? There's very few studies. They rely almost entirely on chronotype rather than actigraphy measures. And there's some conflicting evidence of how it affects things like sleep onset latency, REM latency, and PSG studies. So there's certainly some more work we can do, especially looking over time at how sleep quality changes with circadian dysfunction around the physiology. And how does circadian profile differ in terms of subjective and objective sleep quality measures? So looking at subjective reported sleep quality versus objective, there's really no studies looking at both. And how are the pathways forward in terms of researching geriatric conditions going to change? And I think there's more in terms of what I mentioned around how does circadian profile change with age. And very interestingly, and with huge repercussions in terms of public health, we think about how does circadian profile associate with neurocognitive decline and with general morbidity and mortality. There's some emerging evidence around circadian rhythm dysfunction being associated with incipient neurocognitive disorders. These are limited to, cross-sectional and then some cohort studies now that have come in recent years. And how do we disentangle how much of this is circadian, how much is sleep architecture change with reduced slow wave with aging? Really, how do we disentangle this? And then how do we intervene if it is thought to be a risk factor, which is just something interesting to think about. Of course, we have sleep hygiene we can recommend around sleep regularity, CBTI, to work on that, but they're not really kind of specifically for circadian rhythm. For sleep duration, how do we intervene? Of course, we know it's a tough thing to improve once we've improved people's insomnia or other kind of sleep dysfunction itself, but working on that. And slow wave sleep, how do we enhance slow wave sleep if it's a risk factor for longer term cognitive decline or for morbidity and mortality? And so there's been, we could think about things like prescribing slow wave enhancers, deprescribing certain agents. And then there's some interesting areas that are really in the more pioneering stage around, is neuromodulation a potential avenue for enhancing slow wave, for instance? And I show this kind of recent excerpt of recent papers that are looking at the review of what has been tried. And these are things like acoustic stimulation, transcranial magnetic stimulation, which is really heavily used in psychiatric research right now. Can these things enhance slow wave in order to be a protective measure for people as they age? And I use this also as an example to think about how we may think about circadian rhythm and other things. Is the research going to point us to a place where we really want to work on some of these risk factors for long-term outcomes, including working on circadian regularity, and if that's a potential help for these folks? On the mental health side, we know that evening chronotypes associate with mental health dysfunction, but very few studies on objective circadian rhythm. And do these associations with mental health disturbance hold in older adults? Because virtually all of this research is done in adults or even young adults. And they, of course, have an interesting profile of having an advancing circadian rhythm with age in older adult populations. And how do mental health symptoms and suicidality change alongside circadian time? These are the graphs I showed of how psychiatric symptoms are during the course of the day. And really, we're pretty early in the days of research around that. So the mind after midnight suicidality overnight, how do mood symptoms and anxiety symptoms change during the course of the day? It hasn't really affected us too much in psychiatric prescribing, thinking about the time of day effects, but it certainly could. You could see how ways that capitalizing on the data around circadian rhythm and mental health could adjust how we treat our patients and how we advise around times of day. So talking specifically about the clinical impact of future research, maybe circadian health should become, more of a core part of our sleep medicine assessment, thinking of integrating things like the MEQ, sleep diaries, maybe even before we see a patient sometimes for really kind of engaged patients, taking a clinical history, which has a clear look at their circadian profile. And how do we optimize circadian rhythm for people who necessarily don't have a circadian disorder, which is an interesting thing to think about. Because a lot of these folks in the research I'm talking about don't have a circadian disorder. It's just showing that they have a different circadian profile, which may not fit within a disorder lens. Is helping these folks going to be helpful for them in the long term? Research evidence could point us to this, and we kind of got to be set up for it. Could this be education, more prescribing of light box therapy, low dose melatonin? Maybe there'll be new circadian psychotherapy models that are more focused on this. And in the future, what I kind of think about is circadian profile, could this have potential to be an additional indicator of health? And there I hearken back to the study I showed, which was an entrainment model of an AI device or an AI model to estimate age based on circadian profile. And is that what's coming down the pike? Is this what we could be thinking about as an additional measure of health as we get older? And so just to briefly touch on a study that I'm working on right now with Dr. Miner and with Dr. Knauer, Dr. Yagi, and Yu Pan. And so we're doing a study right now kind of looking at some topics around this, and I'm going to skip over a little bit, but we have a pretty small cohort or reasonable cohort, kind of around 60. It may increase a little bit here. And it's a cross-sectional study in older adults with a sleep complaint. We collected lots of questionnaires, a one-night polysomnography, a 7-day actigraphy. And just to briefly touch on a couple of findings that are very early and need a lot more development, but we saw that there was significant discordance between these older folks, their chronotype, so their explicit described preference for going to bed later or going to bed earlier, versus the actigraphy and what that captured in terms of their outcomes for MoCA scores, so for cognition measures, for psychomotor vigilance, and for comorbidities in general, which is interesting. And we also saw that interdaily stability, specifically one of these newer circadian ways of receiving information out of these actigraphs, it showed to be really the best model to be associated with MoCA scores and with cognition when compared to chronotype or other circadian data, including circadian amplitude. And that's after adjusting for some characteristics, including like total sleep time, AHI from polysomnography, and other socio-demographic factors. And more data to come, and hopefully this will continue to show us interesting findings as we move forward. So just returning to our objectives, we've spoken about circadian concepts, measurement, assessment, some of the recent research on a variety of health outcomes, and discussing where the future may lie, and ready to tackle some questions if there are some from our crowd. And this is just in architecture, circadian things are becoming pretty trendy as well. It looks like this is a specific designed like modular house that I came across hearing about, that the idea of it is to expose to natural light throughout all seasons, allowing people to stay entrained as best as possible. It doesn't look as homey as most homes, but maybe there's some potential in the future.
You're going to prescribe this for your people with seasonal affective disorder? Go get one of these crazy houses. I love it.
Yeah, insurance companies will definitely support it, I think.
So this was so great, Zach. And again, I just want to really applaud you for this really extensive review of the literature that you've done. Clar has a question. Clar, do you want to ask your question? Because I think that's an area that's really interesting to me too, that Clar's asking about.
Sure. Thank you, Brian. Zach, that was amazing. Thank you very much. It was a tour de force overview of this space and of real clinical significance to our patients. I was very interested that you sort of touched on this Michael Perlis hypothesis regarding the mind after midnight. And I found the suicidality rate increase to be very compelling. But I was just curious if you are aware or have seen in the literature maybe other examples of impulse related behaviors, perhaps ingestion, overdose, drug addiction that may also increase with frequency during that time. Is there anything else in the mental health literature to that effect?
Yeah, I think that's a really terrific point to think about. I'm not, I think we can know very familiarly that there's some literature I reviewed around eveningness being associated with substance use disorders. And I think we know clinically when we see folks with substance use disorders that a lot of significant period of use will be in the evening. And there's a big circadian adjustment to that. And when we do, like conceptually, of course, when we have lower risk tolerance, hypofrontality, all these things should lead us to more risk-taking behaviors, including with substances, which then, of course, are synergistic with that suicide risk. I'm not aware of studies that I reviewed that look at that explicit synergy of this risk-taking time during the night and substance use and suicidality or other risky behaviors that then could mediate this, or how can they work together? I think that's a wonderful point. And conceptually, that link seems clinically like it would be very strong.
Yeah.
I see that Dr. Johnson has her hand up. You can go ahead.
I would comment on that last comment. In the later school start time and daylight savings time literature, there is some data of, when schools are changed, they have looked at risk-taking behaviors and drug use and those things. There is a position and time zone study that shows if you're on the western end of the time zone, you have more suicide rates. There's a Russian study that showed when they went to daylight savings time, they had higher rates of seasonal depression in adolescents. That was the lowest rates when they're on standard time. So some of those studies I think help. And I'm just throwing out there that especially for those position and time zone studies, we need dementia data. I think we could put a nail in the coffin if we proved that having, our clocks mid-set increased Alzheimer's risk. I think we'd get a lot more people on board. So any of you great researchers want to do that study, please do it.
Great idea. I like the sound of that. Brian, you want to go ahead with your question?
Oh, sure. Thanks, Zach. Really did an outstanding job of really reviewing the circadian literature across lifespan from young to old, from psychiatric disease to cardiometabolic disease. Really great job. I too am so interested in this circadian rhythmicity of mood and suicide. And, it's interesting that mood is so low in the morning, but I would imagine that suicide rates are quite low in the morning. And I wonder if it's because, in the morning you're the most sleepy, so maybe you just are less apt to act on something, whereas, the people that are probably committing suicide early in the morning at 2 or 3 in the morning are probably those delayed evening type people where they might be relatively sleep deprived. Maybe they have they're more apt to act during those times because of certain agitation or they're not as groggy as they would be at 7 or 8 in the morning. That just kind of struck me as we were thinking about that.
Yeah, I think that's interesting to think about because it's so hard to disentangle in some ways how much of this is circadian, how much is sleep deprivation. And even within that, as I mentioned, like these are hypotheses stage elements of how to explain it. But they're ones that I think are really informed by for instance, on the sleep deprivation side, that's decades old literature from when they would do forced sleep deprivation for patients. And so the need to disentangle that and think about how clinically it can change things for psychiatric patients, I think is really significant, like you're alluding to.
Yeah, and the strength of that data, the circadian rhythm of mood, just really suggests that psychiatrists really ought to think more about sleep. And I just think about the psychiatry residents at Yale, and they get the exposure to the sleep they get is from my clinic. They get very little exposure. And treating sleep, while I think general psychiatrists try to do it, they probably are not the most expert in it. And I think it's so important.
So Zach, you're in a great position, right, with your training in psychiatry and sleep. Because Brian, I totally agree with you. I think probably a lot of people need to be thinking about sleep more than they are, but definitely in the
psychiatrists in particular, kind of.
Yeah. Well, I see that it is 3 o'clock, so I see there's a message in the chat, Zach, if you want to take a look at that. But I want to also release other people for their next meeting. And then just also say thanks once again, Zach. Great talk. I think we all learned a lot. So thank you for presenting that for us.
I appreciate it. Thanks. For anyone who is staying, I'll quickly answer this question in the chat. So it's listed, when you talk about instability, are you referring to that within a week of time? For example, contrasting night shift workers who maintain the schedule when they're not working compared to those who shift back to normal, and how it affects cardiac and all-cause mortality. I think that's a great question to think about. So we know shift work specific data, I think, is painted a really poor or pretty grim picture on those kind of outcomes that you're referencing. The studies that I was trying to summarize around circadian rhythm, they're mostly, I'd say, it's hard to say. A lot of them are chronotypes, so they're just based on morningness, eveningness questionnaire, which limits our ability to color how much of that is authentically circadian. But then some of the ones that are generally using actigraphy or measuring circadian rhythm, it's no more than a week. And the interdaily stability measure, which is the one, for instance, that we were looking at in the research we're doing right now, that measure is looking between days over the course of a week of data for instance. So it's hard. Could there be that some people are captured under the interdaily stability or under the circadian measures who actually have shift work? I presume it's very possible. It could be a similar mechanism that's overlying it, but I think there's enough evidence to say that just being awake at we could say improper or non-normative circadian time probably carries its own health risks as well, in addition to the moving between circadian rhythms.
All
Thanks.
right.
Thanks.
Thanks, everyone.
Yeah.